So now we'll move into talking about drug therapy for osteoporosis. We'll talk first about the bisphosphonates. The bisphosphonates are medications such as alendronate, risedronate, abandronate, and zoledronic acid. These are medications, they're considered, I like to think of these as the workhorses of treatment for osteoporosis. They have the best clinical data, and also they've in general shown the greatest impact on fracture incidence in our patients with osteoporosis. Actually, let's talk a little bit about bisphosphonates further. So these medications have variable dosing. Alendronate, risedronate can be taken daily. They also can be taken weekly. Zoledronic acid is given as a periodic infusion, so this is a once monthly infusion, and abandronate is taken once a month. So these medications have very long half-lives, and that's the reason that they're can be administered so far apart, once a week or even once a month. These other medications are calcitonin or miacalcin nasal spray, estrogen, a conjugated estrogen combination with bazidoxifene, which is a selective estrogen receptor modifier, raloxifene or Evista, which is another selective estrogen modifier, teriparatide, or denosumab. The goal of drug therapy in treatment of osteoporosis is as follows: to prevent additional bone loss. So in these patients who have osteoporosis, we know they've already sustained a significant decrease in their native bone mass. We'd like to prevent that from worsening. We'd also like to increase their bone mass if possible to start to rebuild their bones a bit and hopefully increase that T-score and make it higher. And then of course to reduce the risk of fractures, because fractures, as we saw earlier, are what confer that significant morbidity and mortality. So if we look a little bit more specifically at bisphosphonates, bisphosphonates' mechanism of action is to inhibit osteoclast-mediated resorption. So they decrease the breakdown of bone. Bone tissue has a variety of different types of cells, but there are two key cells with respect to treatment of osteoporosis. So osteoblasts are cells that actually work to make new bone tissue. And osteoclasts are cells that work to sort of break down that bone tissue. And when someone is younger in life, that's an ongoing process. However, as we age, the process slows down. So what these medications do is inhibit the activity of osteoclasts, so they're not breaking down the bone tissue as quickly. They also bind to the mineral salts in bone, and that's why they have such a long half-life. Alendronate, as an example, has a half-life of years. So once these medications are in the system, they're in there for quite some time. However, that does mean that we can administer them much less often, so they don't have to be taken daily. They can be taken weekly, monthly, etc. These medications have good evidence to support their use to increase bone mineral density at the spine, at the hip. And I have that emphasized because that's where the most concerning fractures occur, hip fractures, and they have been shown to reduce risk of hip fractures. They can actually reduce hip fractures by about 20%. Bisphosphonates, unfortunately, have extremely poor oral absorption. Most of them are actually formulated as an oral, as an oral tablet or even an oral solution. The bioavailability of these medications is less than 1% in most cases. That's very, very low. If these medications are taken with food or concomitant with other medicines, then that can reduce the bioavailability by another 50%. So if it's less than 1% and you cut that in half even further, then there's very, very little of these medications being absorbed. There are many, many different formulations. As I've mentioned, they can be taken by mouth daily, weekly, monthly, or can be even given as an intravenous annual infusion.